Ladies and gentlemen, the Commission, Maryland Healthcare Commission, will come to order. Commissioners, included in your packets are copies of the minutes from the April public meeting. I would like to have a motion for approval. Do I have a motion? One motion. Do I have a second?
Second.
A motion and a second. All in favor, say aye.
Aye.
Opposed? All right, okay, we got that. Okay, thank you. All right, very good. All right, Commissioners, you've received a written update from all of our centers. You've had an opportunity to read these updates and digest a lot of the activity that the Commission is undertaking. Does any Commissioner have any questions on the written updates that you received? Any questions at all? Anybody on the phone? Any questions?
No questions.
No questions.
Okay. Do any of the center directors have any additional updates? Mr. Director?
So with your discretion, recognizing that a host of factors today made it complicated for us to get everyone here in person, Commissioners O'Connor, O'Grady, and Metz are on the line, but recognizing that in the challenge of being online, I'll forego my update. If we can go directly into the action items that are for us today, I think that'd be most helpful and appreciative.
Very good. Mr. Director, before I go, Commissioner Thomas, do you have an announcement or recognition?
Well, thank you, Mr. Chairman. As you know, we're recorded, and actually some people watch us. And I have a young scholar here who has been watching and believes David Sharp's a star and wants to work with Teresa Lee. Her name is Dr. Devlin Jackson. Can you stand up, Devlin? I want to acknowledge Devlin. She's a project study coordinator at the University of Maryland School of Public Health, and we're working to better articulate some of our scientists with the work that we're doing here. Thank you very much.
Thank you very much, and welcome. We really are happy to hear that you watch us on television. I don't know what our Nielsen ratings are, but we there's a lot of room for progress, so thank you very much. The next item is the modernization of the Maryland Certificate of Need program, an interim report by the Commission. Last year, the chairs of both the Senate Finance and the House Health and Government Operations Committee requested that the Commission recommend changes to our health planning and CON authorities that would better align our planning and CON functions with the health reforms that are now underway. The chairs of both committees made very specific references to hospital regulation, and they emphasized the importance or the need to align the CON with incentives under the all-payer hospital model. The Commission was also told to consider other areas of planning and CON oversight that might be appropriate for reform. The Commission decided to address what the chairs had requested through a task force, establishing a task force that would focus on identifying the issues and in the first phase, culminating with an interim report for the legislature and the public, and then a second phase that would focus on the solutions that we have identified for the problem. That would be included in a final report. Our task force was a 16-member task force, including Commissioners Sargent, Hafey, Metz, and O'Grady, and they have been meeting since January of this year. Commissioner Sargent and former Commissioner Francis Phillips were the co-chairs of the task force. Commissioner Sargent and Paul Parker are going to present the findings of this interim report. Other task force members, Mr. Barry Rosen and Mr. Adam Kane, will join our commissioners, Randy and Paul, at the table and present their views. If you approve, if commissioners approve, the Commission will submit the interim report to the Senate Finance Committee and the House Health and Government Operations Committee. And we will post it on our website, and we're going to invite the public to comment. So, gentlemen, the floor is yours. Tell us the problems and difficulties you have identified in the current regulatory structure.
Thank you. So before I started, I wanted to thank Commissioners O'Grady, Hasty, and Metz, and Commissioner Phillips for their assistance with working on this committee. Also, Paul has done a great deal of work, and Mr. Rosen and Commissioner Kane as well for this participation. So some of these initial slides we've already covered, the chair's covered, so I won't spend too long on them. But our charge was to look at the major policy issues for CON regulations, to review what other states are doing, to recommend revisions to the statute and to our state health plan regulations, and to look for places to create incentives to reduce unnecessary utilization, eliminate, consolidate, or revise chapters of the state health plan, develop criteria to determine service needs, improve clarity and appropriateness, to look for the flexibility that's needed to streamline CON project review processes, and to look for areas of regulatory duplication with MDH and with the HSCRC. We broke it up into phases 1 and 2, which I think of as sort of what's wrong and then how do we fix it. So we're here with what's wrong. Also, to some of the sessions, we're going to get into what is right, what is good about certificate of need, because you have to know both at the same time when we get to what's fixing it. So we set out in phase 1 to identify the problems that need to be addressed, and then we will look for the ideas in phase 2. We've solicited comments from the regulated entities and other stakeholders who are on the task force that we convened to provide their perspectives and discuss the problems and provide advice. And we set out phase 1 in the interim report that you've got. The interim report is one where we have integrated the comments that we received in phase 1. We have not made a definitive determination of what is and is not a problem, as much as we have collected what all the perceived problems are and the perceived places that are working. When we get to the phase 2, we're going to have to come in with the commission with some recommendations. So this is sort of the easy part for us as a commission. We've identified the potential problems. When we get to the solutions, we're going to have to actually recommend specific solutions and agree on them. So I think this is the informative and educational part, but we all as a commission need to be thinking about what the solutions will be so that we can inform ourselves as we go along. We got several common themes that the task force, we met 6 times, I believe, and asked each of the industry representatives and other folks who comment what they thought was wrong with the CON process, whether the CON was necessary, what purpose was it serving. Assuming that it's necessary and it's serving a purpose, then what is wrong with it as it exists? Does it have the proper scope? And are the way we're doing CON, can it be streamlined? Are there unnecessary pieces that can be cut out?
Commissioner, could you please move your microphone a little closer? So
Does that work?
That's better.
Okay, sorry about that.
No, it's all right.
Shall I start over?
No, that's we want to hear more of wisdom.
Absolutely.
That's absolutely the case.
So the common themes that emerged were most of the regulated facilities, the folks who had CONs, saw a need for CON regulation in some form. There was definitely more support for keeping CON than for eliminating it. I'd say that comment here is the idea of CON. I don't think that you can necessarily talk in abstract about all certificate of need for all areas. We're really, when we get to recommendations, we're going to have to look at, is a certificate of need needed for this service? Is it needed for this facility? There's not really been a push to just eliminate CON as an entire concept. So nobody really took the position, get rid of CON altogether for all purposes. The substantive discussion then was of the need for the current scope and the appropriateness of the current processes for some types of projects. We looked at the literature. Our esteemed chairman provided some literature. Paul provided some literature, and I think Barry sent some literature. And we went through it. The reviewed literature doesn't really provide strong support for CON regulation as being effective in controlling costs or improving quality. That doesn't mean that it isn't in some areas. It's just it wasn't a strong scientific support that you will improve quality if you impose a CON or you will reduce costs. At the same time, there's a recognition that CON regulation shapes our healthcare system. In Maryland, where we have ambulatory surgery, home health, hospice, there are lower per capita numbers of facilities and levels of capacity than in some other states. That CON is an established fact on the landscape. The supporters saw the benefits of CON regulation in reducing overcapacity, facilitating more equitable access to care, and more appropriate care. Some supporters saw limits on growth and new market entry could be beneficial in some contexts to protect expensive investments in facilities, reducing opportunities for fraud, the potential for overwhelming the oversight capacity of licensing and certification agencies, and in keeping labor shortages from becoming more acute. CON regulation at the same time imposes significant direct compliance costs in regulated facilities. So the review process can be complex. It often involves expensive legal and other expenses. CON regulation limits competition that may increase costs and may limit new competitors who have innovative approaches for shaping care delivery. So, and one comment that was very interesting we've got is that CON regulation can encourage a silo perspective on the appropriate role of particular types of facility at a time when you may need more flexibility. The role of facilities in outpatient treatment or getting out of the hospital context to long-term care versus home treatment, things like that, those lines are blurring, and CON can have a very rigid set of boxes that everything must fit into. So one of the comments was that some folks felt that inhibited the ability to sort of seamlessly adopt these newer approaches. The role of CON regulation, the flip side of the folks that commented that it was needed for quality improvement is that CON regulation is limited as a tool for quality improvement because it is a one-time shot. You can come in and gauge the quality of someone when they seek a CON application, but it's not a process for going forward and reviewing whether quality is maintained, whether quality continues to be comparable to the industry standards, and things like that. And quality improvement objectives may be better addressed with more appropriate tools, including ongoing regulatory supervision by licensing and certification agencies. CON regulation, however, is the primary way for MHCC to implement its objectives for healthcare facility services. We just need to make sure in our reforms to make sure that it's focused on those purposes. So with those themes that we discussed, that's sort of an overview flavor of what we discussed with respect to each of the areas in the task force over which we have CON regulation. The key problems that were identified, the scope of CON regulation is outdated. You probably got some flavor of that from some of the comments. The review processes for handling different types of project review are underdeveloped, but not all projects need the full review that may be currently imposed. There may be pieces of update projects that can be exempted from the review that aren't necessary to serve the purposes of the regulation. The state health plan regulations are in some places outdated and overly complex and need to be better aligned with the evolving all-payer model regulating total cost of care. The average period of time needed to review and act on CON applications is too long. The period for completeness review and developing recommendations is often excessive. The information requirements imposed by CON and regulation are excessive or duplicative. Performance requirements for approved projects are outdated and inflexible, and the capability to obtain broader community perspective on projects is underdeveloped. Now, I'm reading this to you. These are not necessarily conclusions that all of these are problems in all contexts that have to be solved. Remember, this is the compilation of the concerns raised by people in our task force. So as we're going forward and evaluating what to fix and what to do, we should have in mind avoiding these problems is the goal. But I'm not necessarily here to present an indictment. It's like a conclusion that in every context, each of these problems apply. It's more of a, these are the problems people are seeing that we should be aware when we're trying to fix things and make recommendations and changes. Otherwise, it sounds like I'm making a scathing indictment of the current system. What I'm trying to do is present our sort of menu of places we need to start doing our work of making recommendations from. So taking those lists of problems and concerns forward, what phase 2 should do is where we need to roll up our sleeves and come up with specific recommendations. Where can we take a regulation that is asking for more than is needed to accomplish its goal? Or where can we find a place where CON isn't serving the purpose that is needed? Or where it may be in place, but a better regulatory scheme would address something in a different way. And we need to nail that down to a specific list of things that we can pass that to the legislature. So we're going to reconstitute the task force. The report you have in front of you has who's on the task force, and it's a good selection of a cross-representation of the regulated industries plus the consumer representatives, commissioners. We're going to consider the mix of stakeholders and whether we want to add anybody, an additional perspective. If there's a missing perspective that needs to be added, this is a good time for us to do that. And there was the task force, where we say up here we're going to develop guiding principles to frame objectives for reform. That's come out of the discussions in the task force. The folks on this task force would like to say, well, what are our principles? What is CON supposed to accomplish so that we can measure it? So we are going to solicit specific and detailed ideas from stakeholders to address the problems and the issues identified in phase 1. So we want a list of, from the tall to the small, how would you reform it? And it can range from eliminate CON in this area to, when you file it, we should only look at these 2 things instead of the 3 things, to something else. So we want the big and the little changes so that we can, if we're not going to be able to accomplish a big change, we can at least fix things that are smaller and need to be fixed as well. The meeting agendas we're planning to do to the phase 2 task force will be built around the key areas of reform, right, that we just went through: the scope of the regulations, the project review process, how to make it go faster, fitting it to the project under review, meaning are we reviewing the right things? Are we reviewing too many things, considering what the CNN is supposed to serve? Are we reviewing things that don't need to be reviewed? Looking for ways to simplify the state health plan regulations and prioritize the issues, and then reforming the post-approval process, and looking at what changes after CON approval would need reapproval and what would not. So the last thing is we're going to try to develop consensus to the extent possible on law and regulatory changes that are practical and best address the identified problem. Develop a final study report. The report due December 1 with recommendations to the committee chairs, the legislative committee chairs. I think to think about this, develop a consensus to the extent possible is something that all the commission members, we need to think about this. And I'm thinking about ways to inform the commission of what's going on rather than show up with a report at the end of this, because there may not be a consensus on things that we as a commission want to recommend, right? Or there may not be unanimity even if there is consensus. So I'll be thinking of ways to how can we inform you guys and prepare the commission for making a decision rather than show up with a report with a list of recommendations that you've never heard of before. So I think that'll be one thing for us to think about as a commission. How do we get to that period of time? With that in mind, I'm happy to entertain any questions, but also Commissioners Kane and Mr. Rosen, we invited them here to sort of give their perspectives since they weren't representing a particular industry, and Commissioner Kane is representing HFCRC. The perspectives they've had and going through the study process might be of interest to the Commission.
Well, thank you very much, Commissioner Sargent. Mr. Rosen?
There we go. I'm colorblind, so I'm always happy when this works, actually. My name is Barry Rosen. I think it's helpful sometimes when people know your background. It helps help with the delivery of the message. I'm an attorney with a firm called Gordon Feinblatt.
Over my career, I've represented hospitals and many doctors, nursing homes, hospices, home health agencies, and health insurance companies also. One curious thing I found in representing my clients is when they start out and they want a certificate of need, they hate all of your regulations. And then if they're lucky enough to get a certificate of need, they love all of your regulations because it keeps other people from getting a certificate of need and competing with them. So there is this have and have not aspect to people's perspectives on this. If you have a CON, sometimes you like it, and if you don't have it, sometimes you're frustrated by the rules. I am a member of the task force, and I think I could be any number of reasons I'm there. One reason is I'm a lawyer, and I've been through processes here and given clients advice about the HSCRC also, and giving processes there also. I'm not sure it was by design, but I ended up falling into, I think, over the last couple of meetings, into a slightly different role, which is the same have and have not theme. Many of the task force members, not all of them, are representatives of a particular industry and are representing haves. I found myself representing the have-nots, and often what I say at those meetings, not intentionally, but it does happen that way. And I want to share some of that because I'm in a good role for that, because have-nots call me and have been calling me for years. So someone calls a national hospice provider that does really good work all over the country, and they call and they say, we'd like to provide hospice care in Montgomery County. And I say, that's not going to happen. And you never hear about it, but that's not going to happen. Notwithstanding that hospice penetration in Maryland is low compared to other states. It's better in Montgomery County than many other places in Maryland. But the fact is, hospice penetration is low. The fact is that we spend a whole lot of money on the last year of life, and where there is more hospice, there is less money spent on the last year of life. I can't tell you having more hospices in Montgomery County would cause more penetration of hospice services, but it might, right? I don't know if it does. The same hospice national provider might call me and say, I'd like to provide hospice service in Prince George's County or Baltimore City. Now I can say, at least recently, maybe we can accomplish that. By the way, it's going to cost you $100,000 in legal and consulting fees, and at least 18 months before you're even going to know if this is going to work. It might work, and it might not work. Sometimes those have-nots say, no, thank you, I'll go to another state, and some actually give it a try. But again, there are real-world consequences to the requirements here. These time limit and expense barriers also impact the type of providers we do end up. As you know, in the ambulatory surgery area, there is a loophole that you've created and permitted that you can become a one-room ambulatory surgery center, a one operating room ambulatory surgery center, without a certificate of need. You write a letter and it happens. You don't have to convince the commission or staff of anything. You don't have to spend a whole lot of money. And the result of that is there are more one operating room ambulatory surgery centers in Montgomery and Baltimore County than anywhere else in the world. And it's not necessarily the most efficient way to provide ambulatory surgery. The surgeon does whatever he or she does and then waits for the room to be turned over. Whereas if there were two rooms, the surgeon would move to the other surgery operating room and begin surgery while the room is being prepared and go back and forth. But these are the consequences of where we are. At a time when people are trying to have patients get the right service at the right cost in the right place, the notion of modernizing CON is extraordinarily important because there really are real world consequences of all of your rules. I am hopeful that in this process, as the Commissioner just said, that the recommendations that we come up with in the next phase have a cascading effect. That some of them could just be feel-good recommendations. This type of thing has no capital expenditure. There shouldn't be CON, so let's just get rid of it. People might feel good about that, but that's not in your control anyway. The fact is that many of these things should have to go to the Maryland General Assembly to get the change, and the haves would come out of the woodwork, and it would be very difficult to make the change. So the cascading effect is, all right, if this is going to be part of the CON process, how do we make it more efficient? How do we get to ends that we want? And this is power that you have. You can affect things. So what is it that you want to achieve? So there should be process recommendations. You know, right now for some things to get a CON, there are 9 standards and then 7 substandards under all of those. So you have to prove 63 things. So you have to pay me to write 63 pages. And then after I get a CON for a particular client, opposing parties can file 3 levels of appeal after this and say, by the way, sure, they made 62 of those things, but they didn't, I'm not really sure they made the 63rd. It's not terribly important one way or the other, but those are the rules. So if you can't prove on appeal that you hit 63, then maybe the CON gets overturned. And more to the fact, maybe it's 3 more years that 250 people are still being taken by ambulance or helicopter away from a facility where they ought to be getting care efficiently at the right cost, and they're not, because there are 63 standards. I'm hopeful in the cascade that maybe things will be recommending that you study, that it isn't just we know the answer, we need more clinical input or something. And some of the recommendation was, should we study something some more? Finally, I just wanted to comment again, the Commissioner mentioned it. This interim report is your report. It's not the task force's report. The final report is going to be your report, not the task force's report. We're a focus group. That's what we are. You don't need my endorsement. You don't need a vote. You don't need consensus. Our job is to give input, I believe, but ultimately it is your report for you to decide what's important and what are the modernization steps that get the goals that you think are important for the state. Thank you very much.
Thank you very, very much, Counselor. Mr. Kane, do you have any observations you want to share with me?
Sure. Thank you. Adam Kane. I'm a HSCRC Commissioner. Thank you, Mr. Chairman and Director Staffen, for the opportunity to participate in the task force. As we know, subject to the announcement last week, that we were very pleased to see that the governor and the federal administration has reached agreement on phase 2 of our hospital Medicare waiver. For those of you who aren't familiar with phase 2, it essentially shifts us from a acute-based waiver to a total cost of care waiver for Medicare. So in the context of the work that the task force on CON reform is doing, it's incredibly important as the state formulates its new strategy for it to be successful under this waiver that this work proceeds. The mechanics of such a waiver really have all the risk for the performance of the savings and the waiver on the hospital industry and the hospital field. However, the only way the hospital field is going to be successful in the state in general under this model is if there's alignment between hospital and non-hospital providers and delivery systems. So we imagine that as this model gets executed, there's going to be more and more questions that surround HSCRC and MHCC from a health planning perspective as well as a funding perspective. And we would expect to see a pretty significant strategy around care delivery realignment with the goal of improving quality, but also reducing costs in the system and having care delivered in an efficient and more appropriate manner. This is likely to result in, from an MACC perspective, more engagement from the hospital field in health planning and down through the stream of providers and down through the delivery stream in all the areas that you work with. As Commissioner Sargent said, the siloed approach to health planning is probably more likely to be a thing of the past with this type of waiver in place. Also, the Commission should consider the many alignment programs that this Commission and the HSCRC and the federal government have given and will be giving to Maryland as tools to realign the delivery system, and how that relates to the CON process and the CON studies and the tools and the innovation that are needed to realign the delivery system. I also think that from our perspective at the HSCRC, that you have to put some thought into the regulatory structure and the workload in the regulatory structure. This is a commission that works very hard, and the staff works very hard, has a significant amount of workload, as well as the HSCRC. Causing much realignment in the delivery system is going to generate a lot of workload for this commission as well as the other commission, and people would be wise to think of how we're going to staff that and process that efficiently and effectively so as to facilitate the realignment. Additionally, there'll be new elements of data, new investigations, more relevant data that needs to, the infrastructure needs to be created and be analyzed, and expertise levels need to increase in various parts of the delivery system. And finally, as mentioned in Commissioner Sargent's report, there's a role for the public to play here that I guess the language we use is underdeveloped. We would expect more and more public engagement on delivery system realignment and how we do that efficiently, effectively, and take rather complex issues and get quality public engagement in support of a state strategy will be more and more important for this commission as well as the HSCRC. On behalf of Chairman Sabatini and Director Kinzer, we'd like to thank you for the invitation to participate and look forward to working together.
Thank you very much, Commissioner Kane. Mr. Parker, do you have any observations you want to share with us?
I'd like to thank Randy and our ex-commissioner, Franz Phillips, for providing such excellent leadership for the task force. I want to thank Barry and Adam for being very thoughtful participants in that process, and all of our other task force members. I want to thank Randy especially for really kind of getting in and really working on developing the draft of the interim report. And I just want to mention that if anyone's interested in really taking a deep dive into the material that went into being reviewed and discussed in preparation of the interim report, the last page of the report is a list of appendices, and we're just kind of trying to assemble all those and make sure all the links work on our website. But we're giving you the links to follow so you can look at all the comments we received from various people. You can look at the literature. You can look at meeting summaries and the other meeting materials there. And we encourage you to do that if you're interested in taking a deep dive. If you have any problems getting things to download, or you find a broken link, or there's anything we can help you with in terms of information that you're looking for, please send me an email or give me a call.
Thank you very, very much. All right, now we'll take some questions. Are there any questions for the task force members? Yes, Commissioner Wang.
Gentlemen, thank you very much for such an important report. I have just one question. Commissioner Sargent, you stated at the outset that no one on the task force is recommending that we abolish the CON system in its entirety. But based on your remarks, this presentation, Mr. Rosen's remarks, it really feels like the CON process is deeply flawed. You're saying the literature, the data shows it is not controlling costs, which it's meant to do. It's not improving quality. It's limiting access to the market for people who want to come and provide their services here, like in hospice care. It's anti-competitive. It's limiting access to health care for the patients and the people of Maryland. Given all that, why wouldn't we consider the option of recommending the total abolishment of the system?
Well, we probably should consider all options. I'm sort of an incrementalist by nature, so I would say that I think it's the literature probably, I would say more of as a fails to show that it does rather than shows that it doesn't. So, I think we've seen in the paper how good the social sciences is held up when you replicate experiments. I would say that there's not a strong body of evidence showing that it does those things. There's not really a strong body of evidence that it harms them when it's used well either. I think there are some things that we don't do, for example, that other states have done that would be clear, like regulating the number of MRI machines to CON or things like that that are very old school that wouldn't make sense. I think for us, it probably makes sense to ask that question area by area, because regulating hospital CON is a whole different matter from regulating the numbers of a certain type of surgery that we feel needs a certain volume in order to be safe, right? Those are two completely different, while they're both CON, they're two completely different sets of analyses. So I would probably encourage us to ask that same question, but do it on a case-by-case basis, because we could easily decide that we don't need to regulate, home health or hospice, but there is still a role with hospitals and long-term care facilities, that there really are different analyses. The underlying purposes may be the same. With that in mind, I wanted to encourage you that the parts of the report, I didn't go into details on the segment-by-segment problem statements, but those are in pages 12 to 17, and you'll see the same problems, but they flavored them as to the specific segments. That's, I think, worth a look in the draft report.
Mr. Rosen?
Yeah, I was going to try to answer it too, on a more somewhat specific basis. At least my reaction to it is at least twofold. One, it may be inconsequential for a report to say eliminate something, because it's not going to get eliminated, and because it's not up to you, and it's really embedded in the statute. So if it's going to stay, then you still could improve the process and deal with it. So I think that's a partial answer. Other answers, I'll use the hospice example again, and this is just my personal view, not the task force view. But I think one could reach a conclusion that erecting a barrier to entry in a rural area is really a very good idea in hospice, because it takes so long to go from one house to another in a rural area. Remember, hospice is primarily provided in the home. And so insulating a hospice provider from more competition actually allows the hospice provider to exist in the rural area. In an urban and a suburban area where people live closer together, you could arguably say, let's have more hospice providers. But you could end up with no hospice providers in a rural area if you opened up competition. At least one could argue that. And so I think it is on a case-by-case basis, but I also think it's doing what's achievable and also perhaps incremental. We can make things better. You don't have the power to eliminate some of this stuff. You could recommend it, but that does not necessarily mean that it does happen.
Yes, Commissioner Thomas?
Again, thank you very much for the report. I'm going to make a comment and then some questions. I'm going to direct them to Commissioner Sargent, but it's actually for anyone up there, okay? So, funny thing about standards. Sometimes we don't know how we got here. So I think that the extent to which we have this burden you described would benefit from a deeper historical context of how we got to this situation. And if the underlying fundamentals have changed, which they have, then we have a basis for change. In the time I've been on this commission, I can remember my colleagues wondering if the all-payer was even going to be around after the current election, okay? And we now know from the top of the administration that healthcare is complicated. So whatever we do, we want to be able to survive the front page New York Times story. It's when those kind of stories hit that the question is, What did you have in place to prevent this? What standards, what oversight, what regulations? So I think it's very important to what extent these are kind of a reaction to that. Now they're an overburden, and how we, again, protect the state and our providers from that front page story. On the opportunity to reconstitute the task force and move forward, I'll put my academic hat on and say that you really didn't have a focus group. So this is my academic hat. I'm suggesting that you actually do focus groups systematically with stakeholders, with consumers, and actually go about this in a very systematic way of getting that input toward that building consensus. I don't know if the term Delphi method, we're different disciplines, but there's a methodology that would actually help systematically bring you to that developing of consensus. So that we could use some of those case studies and other ways. I think at the end of the day, the report would be readable and accessible on many levels. And the last thing is, because hospice was raised, and I hear this often about how much money we spend at the end of life and why hospice is important. I would submit to you that hospice is important for the dignity and respect. I don't care how much it costs. I think our argument is that there's more suffering unnecessarily at the end of life versus it costs more money. So it's a matter of perspective. And I say that because in the communities I come from and that I work with, the data will show that African Americans are more likely to expend much more in that last year of life because of fear and lack of trust, that their life is not as valuable, as the cost of saving them. So we need to factor that into how we language and how we get buy-in from all sectors.
If I may, actually, Commissioner Thomas, I think your points are well taken, and especially the first one, the first set of points you made about how we evaluate the changes when they come. I think that's right. We're going to want to, any proposal to reform, we're going to look at what it's trying to accomplish, and we're going to want to think through what it may in fact do that we're not anticipating. I do think we need to think it through carefully. So the list of potential reforms, or the list of problems is that. It's the list of problems for our target. That we should be thoughtful about what we do with that list of problems next. I absolutely agree.
Commissioner Tamarkia?
I have a question. First, Stephen, I want to thank you. First, I want to thank you all and everybody else who participated on this endeavor. It's a yeoman's job. It's thankless. So I'm thanking you on behalf of the citizens of Maryland because it is going to make a big difference. And I want to encourage you all to think big, think outside the box. This is an opportunity given very rarely where the legislature has said, tell us how to fix it. So think out of the box, go crazy with it, and do something that's really going to make a difference because we don't get these opportunities very often. My question, as you were going through your slides, we talked about the average period of time. Does the average period of time differ based on, the divisions I saw between hospice and hospitals and ambulatory, ambulatory surgery as another thing? Did they differ between all of them? And for each, what is the general period of time that we're talking about?
So we took a look at, and this is actually something you can look at on our website, Appendix G. So it's listed on the last page of the report. We looked at 49 projects, and these are the last 49 CLN actions we've had. So this dates back to, in some cases, applications that were filed in 2011, decisions made basically in the period 2013 through early 2018. And the average from application filing to final action or withdrawal, because we included those docketed applications where the applicant withdrew, and usually that was after they got a negative recommendation. We considered that in there too, because it essentially is a project review that was completed. They took about 11 months. That was the average. And we broke that down into kind of the two main segments of the review process. When an application is filed, we ask questions and we get it docketed, which means it's a complete application. The average there was 4.2 months. And then after it's complete and you're reviewing it to get to a point where a recommendation is made for final action, that's another 7 months, a little over 7 months. There is a big difference between those averages and the median. So the median amount of time from filing an application to final action or withdrawal was 7 months. And that breaks down into 3.5 months for completeness review and 3.7 months for from docketing to final action. And so, you know, over half of the applications actually are not that long. They take about, 7 months to do. And in terms of further kind of breakdowns here, we really looked at contested cases in that mix, which I think were a little under 20 cases out of the 49, and then uncontested cases. And you see a really stark difference there. The contested cases take much longer. In fact, when you look at uncontested cases, we're getting the total time from filing to final action down to like 6 months. So, and that's because that's the way we process applications. We've never processed them on a first come, first served basis, because we know that's not going to work. That's going to create big backups. So we're always kind of, I use the term triage, maybe that's the right word, but we know that there are some that are simpler, they're more straightforward, there's no one really objecting to them. We try to get those through the process quicker. We take longer with the larger projects, the more complicated projects, and those tend to be the ones that get contested too, where we have interested parties. So we're not coming anywhere near the expectations of the statute. The statute says you should get these done in 90 days if they're uncontested. It's actually pretty hard to even get an application docketed in 90 days unless, you have a perfect application that arrives in your doorstep, and we get a lot of really imperfect ones. And then we have 150 days for contested cases, but we're not coming close to meeting that on an average or median basis. And the only relief that's allowed under the law is, I think, after like 200 some days, you can go to a judge and say, look, I want to get a decision out of this commission, and the judge can say, okay, make a decision. No one ever does that because people don't really want decisions that badly. I mean, it's they want the right decision. Hopefully, they want a positive decision. So, that's not something that people exercise, but that's basically what the law says about timing. And I'm not aware that we've ever come that close to meeting any of those statutory targets. And I think my experience has been that that's kind of the way it is in most states. Most states have pretty unrealistic project review timelines, and they're just not met. But I think my own perspective is we try to do a better job on the ones where I think timing is more of an issue. If it's an existing facility that wants to expand, they want more operating rooms, they need some more bed capacity, they're really coming forward with a project that's meeting a need that they're experiencing right now. I think you want to try to get those done quickly, and that's where I think the most pain is inflicted by taking too much time. We take way too long to review projects like new hospitals or relocating hospitals or introducing new services, but those are a different type of project. It's not like, if we take more time to get it right, we're really, imposing great burdens on that facility because we're not, talking about something that they need immediately. It's something that they've typically been contemplating for a long time and doing a lot of planning and preparation for anyway. So if I could just make
sometimes I just felt a little bit like the lawyer whose client is talking a little too much. But I think one of the points that was brought up is that if the CON process can be used for sparking innovation, it is actually on the side of the innovations where it's most difficult for us to address, whereas the routine, the established actors are seem to get through the process a little more quickly. How do you realign this process, assuming that it's going to continue in some form, I think is really important. And it's also, I think, important for the commissioners to consider the context of where Maryland is. Adam knows very well that we are in many ways trying to shrink some dimensions of the healthcare system, grow it in areas, other areas, the areas where we want to see some logical reductions are in areas where the CON process exists in its greatest development, if you will. And so working with HSCRC, I think it's going to be very important for us to think logically about how we constrain appropriately certain services, broadly referred to as inpatient services, I think, while also fostering the growth in ambulatory integrated community-based care that I think everyone recognizes is going to be more important over the next decade.
And just a follow-up question. So the 7-month average, does that go into is it part of the 18 months, or is it in addition to the 18 months?
I think these are contested cases, and I think the 18-month actually is accurate because they're at the back side. I agree. If it's an uncontested case, you can get it done in 6 months, absolutely. And I really was making a point. I can't tell you I've calculated it is 18 months. It is what I say to clients, though.
Thank you. As Mr. Rosen suggested, I think the purpose of the task force and ultimately this commission is sort of go by service and look at the details and figure out what are the necessary changes. But at a higher level, just in terms of the purposes of health planning and the utility of health planning, because of Maryland's unique position with this new waiver, if it wants to continue with this waiver and be successful under this waiver, the state does have an interest in utilization patterns broadly in all of these services, especially on the Medicare side, but essentially all payer as well. So however you want to look at the CON process and changes and modifications or recommendations, if we are going to receive the extra federal benefits we're receiving under this waiver, the state broadly is going to have an interest in how utilization patterns develop.
Yes, Mr. Thomas.
And this is just very briefly. Given my fellow commissioner saying, think outside the box, be bold, we don't have this opportunity often, I would really, really encourage you to embrace Commissioner Wang's suggestion. Imagine the CON did not exist. You got to go there to say why it should exist. You got to let us know what it would be like if it all went away. So I think it's a good exercise. Since we have an opportunity to do it, do it.
Okay.
With that in mind,
yeah, with that in mind, I think.
Can I add something, Chair? I just want to say you're right, and those are good points. We have a report in December, which is, given what the task we have, is practically upon us. I'm a little nervous about our being able to get to a set of recommendations that we have consensus on to present to the legislature by December 1. With that in mind, I encourage anyone on the commission, if you have ideas, if you want to join, that's fantastic. If you have specific reforms that you want discussed, make sure that they get into discussion. One of the problems I'm concerned we'll have is the tall, big ideas can take all of the time, but as Barry said, we won't necessarily be able to do anything about that except put a line in a report. If we think that there are 69 things that we're looking at and it's making the process burdensome and there should be 52, having somebody come in and say exactly which things those are not necessary is going to be helpful, because we'll get a lot of comments saying 69 is too many. Well, good, but it's going to be more than one, so which one leaves, right? That I'm a little concerned that we don't get enough specific ways to reform the process at the lower level as well that we can grapple with. So we'll be asking that for staff for ideas, but also from the commission and other folks. It would be incredibly helpful.
Thank you very much, Commissioner Sargent. Before we have a motion, are there any questions from any of the commissioners online? Any of the
No, this Commissioner Metz. I'm fine.
Good. O'Connor.
Yeah, O'Grady, I certainly have, been at all the meetings or been on the phone, so I'm quite comfortable with this report, and I'd like to congratulate the staff on the good work.
At that point, I would like to have a motion to accept the Commission's interim report to the legislature. Do I have a motion?
So moved.
Second, Commissioner Thomas.
Second.
All those in favor, say aye.
Aye.
Opposed? Any opposed? Okay, the report is approved. Ladies and gentlemen, I want to personally thank the task force members for the work that you put into this in developing this interim report. I read it fairly carefully. It's a very balanced report. I think that it does, in fact, reflect the sentiments of the Commission. On page 2, I just noticed it. I noticed it last night, but I think it's quite remarkable statement that says the Commission holds strong perspectives on areas of CON regulations that are appropriate for reform, but is mindful that any reform will require collaboration of the General Assembly, other executive branch agencies, regulated providers, and the public. So following Commissioner Wang's view, think big, following Commissioner DeMarchio, what she has said, well, let's not go crazy, but try to maintain some kind of diplomatic relationship with reality, and we'll look forward to a great final report.
Wait. If you want diplomacy, why am I doing this? I feel like we made a mistake in the staffing. I'm just.
No, you didn't. All right. Thank you very, very much, gentlemen. Thank you. Okay. Item 4 is a certificate of need. The consolidation of Adventist Healthcare Shady Grove Medical Center and the Adventist Healthcare Behavioral Health and Wellness Services. Adventist Healthcare requests an exemption from certificate of need for the consolidation of a special psychiatric hospital. Adventist Healthcare Behavioral Health and Wellness Services and the General Hospital. Kevin McDonald, Chief of Certificate of Need, will present the request. Kevin, the floor is yours.
Thank you. Good afternoon.
Thank you.
As Mr. Chairman said, this is a request for an exemption from CON to merge Adventist Behavioral Health into Shady Grove Medical Center. Adventist Behavioral Health and Shady Grove are located adjacent to one another on a campus in Rockville. Shady Grove is an acute general hospital licensed for 266 beds. Adventist Behavioral Health is a special hospital psychiatric licensed for 117 beds. Both of them are subsidiaries of Adventist Healthcare. The proposal is to merge the behavioral health beds into the general hospital so that its psychiatric beds will be under the general hospital license. I'll come back to the reasons and perceived advantages that this change will bring, but first I just want to remind you of how our regulations deal with exemptions. The CON regs permit exemption from CON review for the merger or consolidation of 2 or more hospitals or healthcare facilities if the facilities are part of a merged asset system, which is the case. An exemption can be issued if the Commission finds that the proposed action is in the public interest, is not inconsistent with the state health plan, and will result in more efficient and effective delivery of health services. Looking at the rationale for the proposal and the advantages to Adventist Healthcare and the broader public interest are as follows. under its current status as an institution for mental diseases, and you recall looking at the Anne Arundel Mental Health Hospital last month, we talked about the something called the IMD exclusion, which means that a hospital of more than 16 beds does not get the federal portion of Medicaid paid. So right now, Adventist Behavioral Health is considered an institution for mental diseases, and thus the federal share is withheld. Since the IMD waiver, and that is something that Maryland and a number of other states have participated in, was rescinded a couple of years ago, Maryland Medicaid has chosen to continue to cover the federal share. So that currently IMDs are being paid what they were under the IMD exclusion. However, there's no guarantee that that will continue, and it is money that comes out of the general fund. So if behavioral health were under Shady Grove, it would get out from under that IMD status. The Maryland Medicaid program has estimated that this proposal, which they support, would save Maryland's general fund about $4.5 million annually. Looking at Medicare, under its current status, Medicare pays about 70% of behavioral health charges. If the beds were licensed as part of a general hospital, that goes over 90%. As well, the consolidation will bring some relatively modest operational savings. Probably one of the more important aspects of this in reading their proposal is that receiving GBR allocation allows for a predictable and stable revenue stream for the behavioral health service, allowing it to proactively focus on reducing unnecessary utilization. Looking at financially at the bottom line, as part of Shady Grove, the behavioral health program would turn what is averaging kind of an annual loss in the $2 million range to a modest gain. So the question before the commission is this proposed merger in the public interest? Is it consistent with the state health plan? And will it result in more efficient and effective delivery of healthcare services? Staff believes that it is in the public interest. The public has a strong interest in the availability of behavioral health services, and Adventist Behavioral Health is an important provider in that sector, and one of the largest in Maryland. In addition, changing the facility status from a special hospital that puts it under the IMD exclusion to a unit of a general hospital will reduce the contribution that Maryland taxpayers must make. Looking at the state health plan, staff found no inconsistency with any of the standards there. In terms of the contribution to more efficient and effective delivery of health services, a stable and predictable revenue stream will allow for more proactive preventive healthcare provision and an improved outlook for the long-term viability of behavioral health services. There will also be some modest improvements in operational efficiencies and effectiveness, though it seems that they could be achieved with or without the merger, since this is already a merged asset system. So accordingly, staff recommends that the commission approve this request for certificate of need exemption. And with us today from Adventist are Dan Cochran, the Chief Operating Officer and CFO of Adventist Healthcare Shady Grove Medical Center, Marcel Wright, the Vice President for Behavioral Health and Wellness Services for Adventist Healthcare, Robert Jepson, Vice President for Business Development, and Howard Solins, their attorney.
Welcome, Mr. Cochran, Wright, Jepson, and Councilor Solins. Okay, are there any questions for Mr. McDonald? Any questions at all? All right, do I have a motion to approve the exemption from the certificate of need for Adventist?
So moved.
So moved.
All those in favor say aye.
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 Any opposed? Okay, the ayes have it. Congratulations on your exemption. It's our pleasure. Thank you very much. Okay. The next item has to do with Maryland Practice Transformation, the Maryland Practice Transformation Network. Melanie Cavalieri, is that correct, Cavalieri?
That's the correct Italian pronunciation.
The Italian pronunciation is the correct pronunciation. Right. I imagine. Melanie is Division Chief, Innovative Care Delivery, and Nick, I want to make sure I got this right. Niharika Khanna? Not bad? Okay. Associate Professor, Family and Community Medicine at the University of Maryland School of Medicine and Director of the Maryland Learning Collaborative. Both ladies will present on the performance of the Maryland Practice Transformation Network. In 2016, the New Jersey Innovation Institute was awarded a practice transformation grant by CMS. They partnered with the Commission, MedChi, and the Maryland Learning Collaborative to transform participating practices in Maryland. Well, thank you very, very much, and the show is yours.
Thank you, Mr. Chair and Commissioners, for allowing us to present on this today. So what we're going to go over briefly is an overview of the program and partnership, give you an update on the enrollment and assessment results, as well as some data from the quality resource use report from CMS, and finish with some key initiatives. As we begin, I wanted to just start out with the role of MHCC in this program, which is to assess the program impact on quality and cost, analyze the effectiveness of select care delivery interventions, and provide ongoing feedback to the program implementers to support continuous rapid cycle quality improvement. And with that, I'm going to turn this over to Dr. Khanna. Okay. Thank you. And thank you to Mr. Chair, Dr. Chair, and all the commissioners. I'm very pleased to be here. I have worked with the commission for several years, and this has been the first CMS project that we've done. So the Practice Transformation Network that we are going to report to you on is a CMS-funded project and comes with CMS directives on how to transform the practices, how to support them, what kinds of technical assistance, what kinds of data to collect from them, and a limited amount of data comes back to us from CMS to reflect on the changes that we're going to see in practices. So I'm going to start by telling you what is practice transformation in this project. Practice transformation tends to have a different meaning in different projects. So in this particular one, we are looking at providing practices, ultimately providing more efficient and effective care, improving patient outcomes, and preparing clinicians to participate in new payment models. And in addition to taking them towards new payment models, we're also increasing awareness in the practice community on MACRA. And these transformation and care delivery redesign projects, this one in particular, is designed to attune practices towards population health, to help them to get to a place where they can reduce costs for patients that they care for in their own population, and promote a patient-centered healthcare delivery within those practices. So our work is really to show practices that they can be leaders, that they should and can work as a team together in the care of the patient, which is to take away from the old dogma where everything in a practice would feed up to a physician. But in today's world, more and more we're training practices in teamwork where every member of the team functions to their full capacity, to the highest level of their license, and participates in some aspects of decision making within the practice. We're also attuning them to receiving and acting on data and that has been always quite a challenge when they get into practices. In addition, in practices, the methods of communication have never really been streamlined, and that has been some of the work we've done in this particular CMS project, which includes communication with the patient, their families, and then amongst the team, and then with those that they report to, those that are their peers and others that are in the healthcare system. One of our goals, and actually 3 of our milestones, are specific to the business of running a practice, and those are all mandated by the Center for Medicare. We have seen practices to struggle a lot with understanding the business as it is going to be in the future. This is the future of medicine. So those have been some of the work that we've done in practices. So to tell you a little bit about the Transforming Clinical Practice Initiative, so you're probably thinking all these terms, Practice Transformation Network, then the Transforming Clinical Practice Initiative. The parent group under which all of these projects come is called the Transforming Clinical Practice Initiative of the Centers of Medicare and Medicaid. And under that, they fund 29 practice transformation networks around the country. We are part of one that has 3 states. There's New Jersey, Maryland, and Puerto Rico. And the prime on our grant is New Jersey, and in Maryland, we're a sub from that. This project was established in April of 2015, and it ends in September 29, to be exact, of 2019, which is next year. So we're pretty much in our year 3 of this project. There has been a huge investment by CMS in this particular project to support practices, and it's to the tune of $685 million, which has been expended towards supporting all of these practice transformation networks. And each of these is of different sizes. So, for example, in Maryland, you'll see we have just over 800 practitioners. In other states, they have different numbers. We're one of the larger groups in the country. Supporting practice transformation networks to get to practices are groups called the Support and Alignment Networks, which support the practice transformation network in any educational needs that they might have. They also have innovations around information technology. They'll bring us information on patient and family engagement materials, and there's just a wealth of material that comes from the Support and Alignment Network. So it's a well-designed program. The practice transformation networks are the operational sort of guys. They're the implementers of policy for CMS. And the Support and Alignment Networks are those that support us in providing and supporting us in getting to some of the very new educational modules that have been released. So a practice transformation network, therefore, is a peer learning network. It is designed to coach, to mentor, and to help physicians, and also develop physician leaders who can then become peer leaders in their communities. And it allows practices to have an active role in transforming their own practices. It isn't sort of a spoon-fed process. It allows the practice to determine how they're going to transform, what they're going to embrace, and how. And we have been successful, as you will see very soon. We've also we've tried to ensure that there is collaboration amongst practices, and so the way we've done that is to cluster them by geography, where they're located. So, for example, we have a Baltimore City sort of a cohort of sorts. We have one in the county, which is Montgomery County. We have some federally qualified health centers, and then we have one out in Hagerstown. And that sort of has helped us to cluster practices in a way that they can learn from each other. And I think one of the biggest things we've tried to do is to create a learning environment where they're comfortable with asking questions and moving through the paradigm. This sort of pictorially depicts all of the objectives for you, and it gives you a little bit of a time.
Doctor, 1 second.
Yes.
Sorry. And I'm sorry to interrupt the flow. I think it fits right with where you are.
Okay.
I'm trying to visualize the transformation network in terms of, like, if I'm a doctor and I join, once I find out if I'm participating, can you say a little bit, what do I get and what do I have to do? Like, what that looks like from the doctor, just to help me visualize.
Mm-hmm. You just go down, this one.
And if you're covering it,
I am.
feel free to say I'm going to get there. That's fine.
This slide. It'll describe it for you. Okay. So do you want me to do this one now? Okay. And I'll do this one now.
If you're going to do it in the order you want it to do it. That's fine.
Okay. No, I'll get to this. This is a good slide to move to. So to give you a sense of the kinds of practices, these are practices that don't belong to large systems. These are not practices that you see supported by data analysts and CEOs. These are little practices in the community. The vast majority of the ones we have are the ones that don't want to be in ACOs. They don't belong to large systems. Many of them have their shingle up. They're solo practitioners. Or they might have 2 people or a partner who's part-time and retiring. So these are smaller practices where they want to see what is the change, but they don't feel like they're ready to take any sort of risk in ACOs and such yet. And so we tell practices that what we're trying to do is to help you function to the best of your capacity as you move towards advanced payment models, which we think is the future. And so we're telling each of them that we will help you understand what is your profile. You will be amazed to know that practitioners have no idea how CMS looks at them. So that's one of the things we're trying to do. We're trying to show them these are the types of data they're collecting. Every time you drop a bill, the CMS sees what you did and how you did it and how you benefited their beneficiary. Did that beneficiary end up in the ER 10 times in addition to the times they saw you? And how does that relate in terms of cost and quality, which is measured by CMS? So that's some of the work that we are trying to do to help practitioners and their staff. And it's very important for the staff to be engaged to really understand how they can navigate the changes in the healthcare system. So we look at that baseline performance. You have, majority of them will not know how many Medicare beneficiaries they have in the practice. So we'll ask them to develop a profile of what their practice looks like. Who are your patients? How old are they? Do you have more patients who are in the lower SES with no access to computers versus those that are in the higher SESs, have a lot of money, and you can have the best, electronic health portals that is possible to have. So these are the things that we start with that. So it's attuning a practice to what's the future. How can you maximize your electronic health records? How can you tap into the crisp creations that are happening? And then we also start to tell them that you can use electronic health records to collect data. You can ask your vendor to give you data, and some of these vendors are not very forthcoming. They will give you data once a year, or if that, and that too upon request. So we tell them how to write the request. We tell them, okay, this is what you asked for. These are the metrics you want to look at. You want to see how you're doing hypertension, diabetes. Are you good at smoking cessation? Are you doing BMI testing of young patients? So, and unless you look at it as a population from a EHR, polled data set, you really don't know what you're doing for your population. You know what you did in the 6x8 room, but really when it comes to your entire population, you have no idea unless you see this kind of data. So we also attune them. We help them write a request. We help them connect sometimes to the EHR vendors. And then we also support them in building interfaces. We can't pay them to do that, unfortunately, because our funding mechanism doesn't allow us to do that. But if we can find them a grant, we'll help them get that. Sometimes they get these interfaces for free through the EHR with a small payment sometimes. All really depends. And in transformation, like I said, it is a CMS model. So the phases of transformation are very, very set by CMS. It's a prescriptive program. And it comes with a change package. So you would assess the practice to see where they are, and then you would utilize the change package to help them to change, to progress down the phases as required by CMS in this program. We do encourage them to look at best practices, looking at the evidence, try to incorporate evidence where possible, and then to think about other payer remuneration opportunities. There are others. Obviously, CMS is a big payer for this particular model, but in the practice, you will find that there are always other payers involved. So there are other models to consider how they can align with those so they can maximize revenue as well. I think in measurement, this is really where the rubber meets the road, because there is under MACRA a requirement for all practitioners with at least 90,000 in billing to start to report the MIPS metrics to CMS. And so in specialty practices in particular,
It's a question of selecting the ones that are appropriate to the practice. So we have a couple of our coaches are really quite expert, I'm going to say, at helping specialists identify those metrics and then trying to look at their data with them to see if they've been doing well in certain metrics and helping them select, okay, pick this one, pick that one. And that has been unbelievably useful to practitioners. We had one tell us that we were the wonder team this morning, so we're very excited about that. So it is a labor, you know, it's very laborious going into a practice, sending a coach into a practice to assess them and then to make sure that they're connecting with them on a regular basis. I go out when the coach has needs, but with 835, I really have to say, honestly, I've not been told. I wish I had, but I try. To the rest of the previous one? Okay, so I think the timeline is pretty intuitive, so I might just skip this altogether. Okay, so these are our phases. This is the phases that we walk through with them. The first phase is really trying to see if we can set goals with the practice. We ask them what they aim about. What do they want to do? Do they simply want to work with a coach on teamwork, leadership, or do they really want to get into how to improve that practice as a business? Do they want to enhance their ability to talk to patients and to capture information from patients? Do they want to develop a patient board? They're lucky we get a practice that wants to develop a board. The vast majority will tell you that within the limitations of their revenue streams, their methods of functioning, and their specialty sometimes, that they don't want to do too much change. They want to learn some things and they'll see. So we play with them. You know, if they will tell you we just want to set a couple of goals, that's it, then we start there. And as we go, we find that most of them will come on. We have had a little bit of attrition, as you will see on a slide, and which is absolutely to be expected. There's some practices, this is just not for them. They don't want anyone to tell them what to do, and that's quite okay. But the majority have continued to work with us. They've continued to go down these phases with us. We are close to phase 4 for most of our practices. A few are still at 3. So phase 2 is reporting and using data, and that takes us a good amount of time. Phase 2 actually took us a long time to get through. And then we got to phase 3, which is a slightly lighter in a sense, because sometimes these are things that practices are already attuned to. They want to provide better care. They want to have better health for their patients. And then cost is something of a foreign concept for majority of practices, but when you start showing them CMS data that's been coming to us in dribs and drabs, then they start realizing that cost is really a factor. In 2018 under MACRA, there is 10% weightage for the cost of care delivery in each practice. So practices have become a little bit better attuned to that, and we are getting a lot of them up to phase 4 where they are achieving benchmark status. 5 is where we start to graduate them, and they can either graduate back into their workflows the way they were, or they can choose to join advanced payment models, or perhaps some of the new ones that have been introduced in Maryland. So the partnership is, again, with New Jersey. It's the New Jersey Innovations Institute that got just over $40 million for a five-year grant from CMS. And their goal was to reach 9,000 eligible practitioners and providers, and I think they have achieved that goal. And they wanted to save approximately $180 million. And they have a certain methodology that they've been using, which we can bring to you at a future setting. But they are working on how they're going to present their cost savings to CMS. CMS also does their own calculations, so I'm sure at the end it'll be some sort of a match between what we've assessed and what CMS does. In Maryland, our goal was to reach 700 eligible providers, but we have, as you know, exceeded our goal. We are at 838, or I think that was the max number, and we continue to have practices that want to join us. Primarily by word of mouth now. It's all word of mouth. People who know people tell people, and that's how we've been getting them. And we haven't really turned practices away. So if you're eligible, we send your name up to CMS, and if you get accepted, we are here for you. This is a collaboration. So the Maryland Learning Collaborative, which I run, is based at the University of Maryland School of Medicine in the Department of Family and Community Medicine. And we work really closely with Melanie Cavalier and some of the leadership at NHCC. We have had an important partnership with MedChi, and they've really helped us with recruitment and in educational programming. And we have a couple of other partnerships as well. Our quality improvement advisor is at Discern Health. We have the coaches are held under one of the MSOs, and that has really made us much more agile than we ever could be if we hired them through University of State. So these are the partnerships. They're represented on the slide for you. Next one. So we have, as we mentioned, approximately 835, I think it's 838 now, physicians and other practitioners who are participating in this program with us. We have been trying to do practice assessments using the CMS tool, which is called the Practice Assessment Tool, at least twice a year. And in addition, in between, we have visits by the coaches to get them along in the phases. And we are collecting, where possible, quarterly data for each practice. So some practices have not been able to do the quarterly data, which does not preclude their participation in the program. But we do want practices to get into a mindset of collecting their own data, reviewing it, and then acting on that. And we have in Maryland supported MITS, which is the metrics that need to be reported on the MACRA. Although that is not a CMS mandate, what we tried to do was to align it with our PTN activities, so we could do that. That's our enrollment, and importantly, you'll see that there's this sharp curve up there. Right around early 2017 when we really started to ramp up. And you can also see in the lower lines, which I don't have a pointer to show you, but the lower two lines will show you the practitioners that are inactive. These are the folks who initially joined us and said, yeah, we want to be part of this, and then for one reason or the other, they decided not to participate. So that's about 100 folks, or 100, give or take one or two. And that makes it about, out of say 835, 100 don't work with us actively. And approximately 100 cycled off into an ACO, which is where we wanted them to go anyway. So that's one of our successes. So I guess you could say we can take credit for about 700 and some total. And I think the rest are pretty much inactive. That's our enrollment by region, and it's divided up for you by primary care practices, which are about 40% of total, and of active practices. And in the specialty arena, we have approximately 60% total. There, those that have gone to ACOs are in red on both the primary and the specialty maps. And you can see that the clustering is around Baltimore City and Montgomery County, where we were really able to recruit a lot of people. And there is one practice out in Hagerstown. So practice assessment results, as I mentioned earlier, pretty much all of our practices have crossed phase 2 and are in 3 moving towards 4. And you can see primary care on the left and specialty on my right. And you can see that primary care is a little bit ahead, but really not by much. And both of them, both the groups are really coming along very nicely. We're very, very pleased with what they've been doing. This is to show you, as a matter of, I guess, with chronology, you know, where we were at baseline, where we were on September 1, 17, and where we are on 23rd of April when we cut off. And there has been approximately almost 135% change since the beginning. So our practices have really and truly performed well, and we have continued to stay way ahead of the curve for both of the other states that have worked with us. Because of the PR disaster, the natural disaster that happened, they haven't been as active more recently, but in the early days they were, so they're lagging a little bit now. So this will present to you what a milestone looks like. This essentially is extracted from what's called the practice assessment tool. And what you're seeing up there is phase 3-4 of goal. And you will see on the right, the columns represent points in time where these observations have occurred. So June 2017, September 2017, and then April 2018. And I'll just take that very first metric to describe to you how we did this. And you'll see these extraordinary numbers up there for us, 95%, 88%. So what we did, and we've been asked that by CMS, by New Jersey, by everybody, how is it that you're ahead of the curve? And I think what we did was to really recognize very early on that all these practice tools were written in policy language that practices don't speak. Practices speak clinical language. They speak clinician language. So what we did was almost at the get-go was to ask Russ Montgomery, who's my quality advisor, to translate each of those segments into clinical language so that the coach that was going into the practice was not speaking policy to the practices. They were speaking the language that they know. And that's how we had this incredible success. So the first one, for example, is obtain patient feedback, but inconsistently incorporates information, right? No practice will tell you that they're inconsistent ever. And you never want to tell a practice that they're inconsistent with patient information. Right? So we made sure that our coaches didn't go on with this language at all. What we did was to ask them, how do you think that patient feedback is important to your enterprise? Do you incorporate patient needs? If a patient says to you, well, I really need to get in the evenings because I work all day long, what do you do with that? Do you do anything with that? And practices will tell us various ways that they accommodated this. No, we can't stay open after 5. I have these kids that I have to take care of. Or I have a method by which 24/7 my practice patients can reach me. And it is through this answering service that I have that I share with this other guy. And so they can always reach me. So, they would tell you how they do that. We'd also ask them, do you incorporate their input before you do something different? For example, you're going to have a psychiatrist come to your practice half day a week. Are you going to take and accept physician feedback for that? Say, are you going to take patient feedback? So if a patient says to you, well, I only want to see the psychiatrist when I'm depressed. Like, I don't want to see them all the time. And I don't like to come here because then everyone can see me going into that room. So what would you do with that? How would you make it so sensitive to the patient's needs that you would be doing what you want to do, but you would be incorporating patient feedback? So that got them very excited. Yeah, of course, we listen to our patients. We listen to them in the patient room. We ask them to drop these things in the suggestion box. We have this questionnaire that goes out to them. Sometimes we invite them to our huddles. Once in a while we have one of them come. We had one practice that told us that they have a funder of sorts who would invite them and patients all to like a little party on Fridays. All depending on what they were doing. But it didn't sound like anything like this. It didn't sound like this, but they were doing stuff, so we would move them along in that phase. So this was primary care, and this is one where we think we weren't doing great, but apparently we were doing much better than New Jersey and Puerto Rico. So the first one is meeting 75% of improvement targets for 1 year. Just think of your coach going into a practice and saying that to the practice. They would be like, improvement target of what? We said it, CMS said it, was this a target the patient set for us? What target are we talking? So we then had to interpret this for practices to say, if you were working on anything like electronic prescribing, you had a goal that you would electronically prescribe everything that you prescribe, and you would achieve a 75% target goal, then you would have met this. And so when you made it into patient, practice terminology, practices were able to tell you, yes, we are, or no, we aren't, and we don't want to because of this reason. And we would rather do this other thing, which we think is much better. For example, we want to connect to CRISP because we want to get the information contemporaneously for patients that go to the ED. And that was their goal. They met it. That was it. So that's kind of how we did these kinds of successes that you see on there. So not to forget the specialists. The specialists have really and truly been doing amazing. In our program, we are just astounded at how much interest there has been in the specialty community. to work with us. We thought, you know, when we go to them and say practice transformation, we're probably going to be told, okay, bye. To our great surprise, they said, yeah, tell us more. How can we do this? So you can see on here that in that shown improvement in metrics, but didn't react yet. We didn't tell the practice that. We simply asked them, are there any metrics that you measure where you have demonstrated improvement? And we would ask them, so are you doing anything about it yet? And they were very comfortable telling us, no, not yet. But we're thinking, we're working on it. We need resources. We need an additional person, or, you know, whatever they're doing. And so they were, again, moved down those phases based on that. Okay, so this is the first slide from data that CMS sent us. So CMS does this data dump, and I certainly hadn't seen this kind of dump before. And so what happened one fine day, we had data on all of our practices about their quality use and resource utilization reports. And we had 2 years of data, which was completely incomplete. So we thought, well, either we can just wait for complete data, which will probably take 2 more years, or we can move on what we have. So we asked our analysts initially to do this, and then I think NACC did a much better job of putting it together. But you can see on there, if you look at the center grid, which is the central square, you start to see that a lot of practices are clustered there, where they are at average cost and average quality. So what we realized is that a lot of practices that were in this low quality, high cost zone really didn't want to work with us. It was the groups that were average cost and average quality. And this is 2015 on the left. And on 2016, you can see that they're graduating up into the low cost, high quality arena without a lot of intervention from us, because in 2016, we had just gotten up and running. So we're waiting for 2017 data to assess the impact that we've had. We think we may have had some early impact on that, but not a whole lot. But indeed, you can see that these are practices that are very, very motivated and already moving into that arena. And with that, I'm going to hand this over to Melanie.
So I'm just going to briefly go over some more of the reports from the quality resource use report from CMS. So this shows a histogram, which shows the frequency of the practices for ER usage and inpatient stays, comparing it to a national and a state benchmark. So you can see on the emergency room, our practices are doing better than the benchmarks in utilization per thousand. That is compared to an all-payer, not just Medicare. On the inpatient stays, this is a Medicare only. Our practices are slightly more, but you'll see when we get to costs that our costs are actually better. So that could be offset by a lower cost per beneficiary. So I think the trend you'll see in general is that our practices are really showing improvement throughout these metrics. So we looked at the mix. For these particular reports, they had to have a certain number of instances. So this isn't the whole population. This is only people we could compare. So the mix for this was about 50-50. However, for the number of beneficiaries, it was much more heavily weighted to the primary care practices. Looking at the demographics, one thing we looked at was the percent of beneficiary risk, which was for practices that had more than the 75th percentile. So that's a lot of high-risk patients. So you can see a lot of our specialists fell into that category. And they're similar for the 2 years because it's the same practices, really, that we're looking at in 15 and 16. And that same thing applies. This is the percent of patients who had ambulatory, sensitive, acute, and chronic conditions. Those remained fairly stable over the 2 years. So this is where we really begin to see some results. So this is specialty and risk adjusted per capita cost. And you can see that from 15 to 16, we had reduced per capita costs, but also the widening between the benchmark and us. So we're actually performing better than the benchmarks, even more so in 16 than in 15. And this is for ambulatory sensitive conditions of diabetes, COPD, heart failure, and then for all attributed beneficiaries. The next slide shows the performance rates. So the note I want to make on here is a lower rate is actually better on these because these are inverse measures. So you can see, again, that trend from 2015 to 2016, where not only are we improving, but there's less of a gap between us and the benchmark, so we're starting to perform at the benchmark or almost at the benchmark. And so again, those are for the ambulatory sensitive of congestive heart failure, COPD, diabetes, and then all chronic conditions. And then on the next slide, you can see the acute conditions, which were actually outperforming the benchmark in 16. And then 30-day all-cause hospital readmissions, which were fairly stable. But as you know, by 2016, the hospital readmissions program had been in place for several years. So, you know, we wouldn't expect to see a continued severe impact on that over time. So the next three slides really show the volatility. So what this shows is the change in the number of patients and the change in the performance rates. And what I simply want to point out here is that, as we can see in specialists, there's much more volatility, not only in the number of patients, but also in how they perform on those patients. And that's true of all the ambulatory sensitive conditions. COPD and diabetes is particularly pronounced, and then in congestive heart failure as well. So those are the things I wanted to point out in that data. We do hope to have, you know, more years so that we can have, you know, a better trend line to show you in the future. So I want to talk a little bit about what happens at the completion of the program. So what we hope that practices are prepared to continue to implement transformation. So it's teach, advance, or fish, you know, theory. And then also to sustain on building these quality improvement initiatives. Continue to engage in peer-to-peer learning. We feel that's very important and is really helpful for the practices. Using their data to determine the gaps in targeting interventions, and delivering their care in a patient-centric and efficient manner, and then obviously achieving macro readiness through MIPS and APMs. So what are some of the key initiatives that we're doing for this is to complete the follow-up assessments, as Dr. Khanna mentioned, and that's some of the data that you were seeing was the data from those assessments. Educating practices on changes in MACRA and MIPS, and then also on the new models that are coming out, including the new Maryland models. Assisting those practices to transition. So, you know, they ask us, well, what do I need to be doing to get ready? What's going to help me best prepare, and helping them do that. And then at the commission, we're also working with a contractor to develop a Maryland-specific patient family council guidance document that will help them to, because that's one of the requirements under a lot of these programs. You know, they want to be able to incorporate that feedback in a meaningful way, and then measure if it's really working, and then make additional changes to improve that patient experience of care. So that's what we have for you today. Does anyone have questions on the data or anything that we're doing with the practices? Any questions?
Commissioner Thomas?
I'm sorry, I forgot. Dr. Khanna? Okay, so I want you to think about everything you've learned so far in this process. What's the most important thing you like? How would you decide?
Well, I love that the university left me out of the university to do this.
Okay. So you like this work, this kind of work?
Yeah.
Okay.
You know, in December 2009, when Ben used to run his task force for PCMH, I was a member of that. And then in 2010, when they got the resolution approved, we were lucky to establish this Maryland Learning Collaborative in July of that year, and we were funded in March of 2011. And we've been doing this ever since. So it's been what gets me up in the morning, come to work. So yeah, I enjoy it very much. I think it's interesting to see the change in practices, and just when they get it, you know, it's just a joy. It's wonderful.
What do you wish for?
$1 million?
Is it all about money?
To get more coaches, get more outreach, and to really get into these practices. And I think what I would really like is that if a practice is putting forward, you know, the effort to make this change, to connect with the patients, that their efforts be recognized, not just with words, you know, but you got to recognize the sacrifices that they make with the limited resources that they have, and to consider that this is really very, very essential to the health of our population, to get these practices up to speed, and to have the practitioners of the future. And I'll share with you that last month I did the NASDAQ burnout inventory, and I was like, heck, I need some wellness. So I went down to Naples to the National Society sponsored wellness meeting, and I was like, what can you do for practitioners? And I was just listening to the whole story and listening to Dr. DeChance talk about joy in work. And I think we've forgotten that when you come to work in a practice, it's not a hamster wheel. It's really a joyous place to be where you're delivering care, you're doing what you're trained to do, you're improving your work every day. And to bring that joy back maybe would be my next frontier.
Thank you.
Commissioner Sargent?
Thank you. Thank you very much. That was very informative. On the charts you had where we were comparing the practices to the national standard, I think that there's no, well, I don't think, is there like a Maryland set of standards that you could compare the practices that are in your network versus the practice that hasn't done this? You know what I mean? Like almost like a control group. Is there data available for that, or maybe not?
So that sort of brings us into a wider discussion of how to analyze data, because I'm just beginning to understand that this is going to have a lot of data. And we have just put in a request. We've been trying to put it in, but we finally put in a request for claims level data for all of our practices for the last couple of years. But once we get that, in the previous model that we did in the NMPP, what they had in our evaluation program was a propensity match group of practices that we compared them to. And you really have to tease out practices that were in other programs where they're being supported by other methods of support. So all that, it is possible to do that. You can do that, but it obviously takes some amount of effort, time, planning, and obviously the amount of resources that it takes for a good evaluator to do this for you. In the previous model, we had Impact and Jill Marsteller, and we've just analyzed some data on hypertension and the adherence to medication in that, with trying to match our Medicaid population and trying to see what happens in populations that were not supported by us. And we have seen that practices that participate in organized programs like this do have impacts at this very minute level. With hypertension, quality metrics in particular, taking your medications has a little bit of a higher chance in a patient-centered medical home or a practice that is attuned to transformation. So it all depends on what level of evaluation. You're talking evaluation obviously is a can of worms. So it depends on what you want to see and how we can design it.
Thank you.
Yes. So, Director?
My update will tie this all together at the conclusion of the meeting, but I think it's important to note here that the PTN initiative, when David and Melanie originally laid this out, we were planning to work with CRISP to launch this, and CRISP as the prime was unsuccessful. And through David and Melanie's and really Dr. Khanna's persistence, we actually sought and convinced New Jersey Institute for Technology, which was a successful bidder on this, to engage us. But then I looked at it more closely and said, well, wait a minute, there's no shared savings, there's no benefit to the practices. I don't think this is going to work. And to the point that Dr. Khanna makes about the joy of work, the incentives in improving, they've demonstrated that even when there's no shared savings or no payment model underlying this, that you can generate improvement through peer engagement, through learning collaboratives where everyone learns, with the caveat that all of these practices are also aspiring to go into advanced payment models in the future. They're not being directed necessarily towards anyone, but they do show that practices can be engaged, probably not in forever, but for a couple of years as they move advanced care, be it for primary care or specialists. I think is really going to position us well for working with practices as they become more engaged in the now Maryland model going forward, because that's where the gains. We've talked about CON, we've talked about ambulatory innovation. Really, where the cost savings are going to come from are from programs like this, in my judgment. And the Maryland model has a lot of important elements of it, but it is essential that we engage the ambulatory community in a more effective and coordinated way if we're going to shrink and reduce use of acute care services.
Dr. Khan, I have a question that's related to some policy changes that may directly affect you. The Medicare Payment Advisory Commission recently issued a report in which they said that they felt that the MIPS payment system should be eliminated. That is to say that the commission, the Payment Advisory Commission, made the argument that for a lot of physicians, this has turned out to be overly burdensome, and that it's a practical matter. It's simply unworkable. Now, you're engaged in trying to make this thing work for people who are on the ground. If, in fact, the administration, the Trump administration and Congress should eliminate MIPS, would that affect your program very much at all, or would it simply speed up the alternative payment model option?
So that's interesting you asked me this, because this morning we conducted one of our learning sessions, and this was brought up as it has been on the road as well.
Yeah.
I will tell you that some of the burnout we see in practitioners is because of this MIPS.
Is it?
It is because they are so overwhelmed already. They have no idea of what to do with data. I mean, truly, they have no idea. And if we didn't have a coach write the code for them, that yes, you need a numerator of 41 to this, these guys have no idea. And if MIPS went away today, it actually is, pardon me? Oh, define it.
Yeah.
Oh, a merit-based incentive payment system.
Right.
Right. I'm sorry. So that's what that is. And under MIPS are 300 metrics that have been developed by the CMS, of which they tell practitioners, you may pick any which one you want. So, and then they title that page QPP, which is Quality Payment Program. It does not say MIPS on the website. So these poor practitioners don't know where to find it. Just think of the logistics of a practitioner who's out in, wherever, Rockville, trying to find the MIPS metrics under MIPS.com, CMS MIPS. They can't find it. So, I mean, these are just simple things for you. And people who are really wonderful practitioners are so daunted by this. They think, oh, my God, I must be stupid. Everyone else is doing it. So I think I should hang up my thing and go away and close the shop. So it is a real problem for practices to do this on their own. Absolutely.
Okay. All I wanted to know is whether this would affect you in a negative or a positive way. It seems to me that what you're telling me is that if we get rid of this modern rendition of old broken down Soviet central planning MIPS, this would actually help things along for members of the medical profession, right?
I'm going to speak for my dear colleagues and say absolutely. Nobody needed MIPS.
Thank you. Let the records say that it's something we can share with people who are perhaps not familiar with it. They're going to be shocked.
Does the chair have any opinion about it?
Oh, no, of course not. I try to keep my opinions to myself.
How's mine?
Okay. Any further questions? Thank you very, very much. It's been great. Melanie, thank you. Okay. The next item is with telehealth. It's a telehealth grant award, mobile device supported medication assisted treatment for opioid use disorders. Yvan Lenoir, program manager, will present on a telehealth grant award to the Mosaic Community Services for the use of medication-assisted treatment to underserved Maryland residents with opioid dependence. This is through telehealth. The project goal is to increase the access to addiction treatment in a jurisdiction that is currently lacking that capacity. And joining Ms. Lamar in the presentation is Oleg Tarkovsky. I got that right? Okay. Division Director of Clinical Services at the Mosaic Community Services, and Yvette Jefferson, Program Director of Partners in Recovery. Thank you all very much for showing. Tell us about it. Yeah, turn on the mic so you know we can all hear you.
Yeah.
Move it really close to
I'll still make you start over.
Right.
No,
Is that better?
I'm in charge. You will not start over. Go ahead.
All right. So over the last 4 years, the Commission has awarded and worked with 13 different organizations to implement innovative telehealth projects in the state. And these grants have been varied in focus and nature, which provides us an opportunity to assess the effectiveness of telehealth with various types of technology, patients, providers, clinical protocols, and settings. And so with each project, we're able to learn more and share these learning lessons with stakeholders, both nationally and locally, to help inform improved practices to assess where the need is, as well as assess the willingness and readiness of organizations and patients to use telehealth. Findings also help inform on how to use telehealth to deliver care in an integrated approach among primary care, specialty care, and any necessary community support, and to inform on the design and implementation of current and future telehealth projects. So we released the grant application for the current project in January, and we received 4 letters of intent and 3 applications in the next month. A review of the team comprised of a physician, representatives from Maryland Medicaid, and internal staff reviewed the applications and selected Mosaic Community Services for funding. The goal of the project is to expand access to a medication-assisted treatment, or MAT, to Maryland residents with an opioid dependence where treatment is not readily accessible. And so the grant will operate for 18 months, starting this month and going through November 2019. And approximately $346,000 will be dedicated to the project. And so we believe that there's a great need for this type of project. The number of deaths nationally from opioid drug overdoses has more than tripled from 2000 to 2015. And in Maryland, opioid-related deaths have increased by about 75% from 2007 to 2015. MAT is an evidence-based service that provides treatment for substance abuse disorders that combines medications such as buprenorphine with behavioral health services, and has been proven to help patients in treatment, to help patient retention and increase recovery rates. However, only about 10% of people who need such treatment actually access it, and this is in part due to stigma that's related to the treatment, so the specialized programs and the location of these programs. There's still stigma around that. There have been state and national efforts aimed at increasing access to treatment and boosting overdose prevention efforts, among other things. In 2015, the governor signed the executive order to establish the Heroin and Opioid Emergency Task Force to prevent, treat, and reduce heroin and opioid abuse. And in an effort to also address access issues, the Drug Addiction Treatment Act of 2000 was enacted to enable individuals with opioid disorders to seek treatment outside of specially licensed opioid treatment programs and facilities to other facilities where they may be more comfortable seeking treatment and staying in treatment. So the current project aims to support statewide efforts to address treatment access issues by implementing an innovative project to optimize MAT through telehealth. The goals of the grant are to increase access to a licensed healthcare practitioner with expertise to provide masks, support healthcare professionals in addressing this needed service through an integrated approach, while also using CRISP to find information on medication prescriptions that patients are on and also on hospital utilization, and increase treatment retention and improve overall addiction treatment outcomes. And so the initiative aims to also establish telehealth capabilities and protocols for mass sport addiction treatment clients. So I'm now going to turn over the presentation to Oleg and Yvette to provide us with more information on the program, and we're very excited that they were able to join us today.
Welcome and thank you.
Good afternoon, Commissioners, and thank you for having us. And first of all, I would like to say thank you for giving us an opportunity, both financially and to do this work. So telehealth for Mosaic Community Services is not new. We have been doing telehealth with mental health services now for about 3 years. And I believe we're the largest outpatient provider of such service in the state of Maryland, serving over 1,800 patients, providing tens of thousands of mental health services using the technology. I'm not sure how familiar you are with what telehealth is, so I'll just give you a brief explanation. Telehealth is no different than health services. The only difference is the patient sits in an office potentially dozens of miles away from the doctor. Other than that, the services are delivered in a very similar fashion. There is a facilitator that's typically located at the site where the patient is, and at the beck and call of the physician, allowing them to either manipulate the patient using the tools to assess the patient or provide any other additional services the physician may require them to do. The need for this particular project arose from lack of existing addiction treatment services in Montgomery County, specifically for the population we're describing here in this project, which is the underserved, the Maryland public mental health system. So the goal of this particular project in Montgomery County is for Mosaic Community Services to take over, at this point, a defunct program that has served in some capacity to provide addiction treatment services for the last couple of years through Family Services, Inc. Family Services, Inc. is another affiliate of the Shepherd Pratt Health System, just like Mosaic is. And our goal is to establish an IOP, an intensive outpatient program for addiction treatment at that site. And we think we can get off the ground within the next couple of months and have it fully functioning through the next year. Our goal is to serve about 100 patients via this telehealth program. And as with any healthcare service, we're not just looking at the quantity of patients we serve, but also the quality of that service. The initial reason for having medication-assisted treatment using the telehealth technology is because the natural workforce is just simply not available at the sites where the services are needed. And we do have some concentration of providers in, let's say, Baltimore metropolitan area that are still under capacity within what their licenses allow them to do. And so using the telehealth protocols, we'll be able to deliver similar services to this population in Montgomery County. So, as I was introduced earlier, my name is Oleg Tarkovsky. I'm the Division Director of Clinical Services at Mosaic, which means I oversee our outpatient behavioral health centers as well as our addiction treatment centers. And sitting next to me here is Yvette Jefferson, who is the Program Director for our Partners in Recovery program, which is the addiction treatment program at Mosaic. Dr. Mark Illuminati is our addictionologist as well as a Medical Director for addiction treatment programs, and he will actually be the provider, the direct provider of these services at the newly established clinic. So what are we trying to do here? Well, as I said previously, Mosaic has been doing telehealth within the outpatient mental health system now for 3 years. And not only have we achieved great results with the number of patients we've served and the number of services we've provided, but also, more importantly, we've achieved measurable outcomes. So in the state of Maryland, we currently use a system called the Maryland Outcome Measurement System to measure how well outpatient providers deliver services to their patients. We measure all sorts of things, but just to give you a quick summary, things like substance use, functioning, recovery, and psychiatric symptoms are all measured through the system. And so what we've asked the state is to provide us individual patient level data on the folks we've served within the mental health population, and compare and then break down that data by the consumers that were receiving mental health treatment services via telehealth versus the ones that got it in person. And after measuring this for about 12 months, we found no distinguishable differences. And so it basically proved what already many national studies have shown, that providing health services via telehealth equipment is no different than doing it face-to-face.
And so for next steps will be, so we are launching the project this month. We're hoping to go live with the technology in August. And then in March 2019, report on implementation progress and some preliminary outcomes. And then October 2019, release the final outcomes. Thank you.
Well, thank you very much. Are there any questions? Yes, Commissioner Sargent, thank you.
So looking at telehealth versus in person, have you purely just moved some things you would otherwise do to telehealth, or have you changed your protocols? Are there things that you can do using telehealth that you otherwise would find it impractical to do if somebody had to visit face-to-face, or vice versa?
There's pretty much no difference. The current process for the IOPs that are operating in a face-to-face fashion is to first assess the patient upon intake, and that is typically done by a nurse and a physician combo. Then the physician gives orders for a particular treatment based on the assessment, and then the orders are executed by nursing level staff on a daily basis. And so whether you do it face-to-face or across 40 miles away, there's no significant difference.
Yes, Commissioner Thomas.
Tough problem, and so excited to see what new technology might bring to this challenge. I think that the claim it's no difference is a testable hypothesis. I think that I push around a little bit more to demonstrate that that is in fact the case across all the different case mixes. But one of the things that I'd like to find out, since you're measuring outcomes based on patient outcomes, we just heard a little earlier about bringing back the joy of being a healthcare provider. And I know many people who work in this area of substance abuse as providers can get really burnt out. Is there any effort to look at how a telehealth model impacts the provider's satisfaction? Is that currently in your mix?
It is. So the project I was referring earlier, that we're in our third year with providing mental health services via telehealth, is a CareFirst Blue Cross sponsored project. They gave us $500,000 to do this in 6 outpatient mental health centers throughout the area. And it was a combination of patient surveys, provider surveys, support staff surveys, and the outcome measures. And all of these sources of data led to similar conclusions.
So the provider feels better, patients feel better, and you have better outcomes. Now, when you do that kind of work, is the recipient of your reports, the funder, and the broader, in other words, do you like publish in ways that the rest of us can learn those lessons, or is this proprietary information that just goes back to your hospital or provider?
Not at all. It's publicly available. Absolutely. We would. I go on these speaking tours trying to advocate for medication-assisted treatment via telehealth because of the issues with workforce development and shortage of workforce in particular geographic areas. It's really a win-win for everyone. The one fear that usually the payer source has about the whole system is sort of if you allow this to operate without constraints, can it go amok? And just basically everybody will start doing telehealth, or at least saying they're doing telehealth, and not show efficacy in both how it's done and the outcomes that it could possibly deliver. But other than that, it's a win-win for the provider, the consumer, the payer, and eventually once the technology gets really good, because right now, in order to operate something like this, the patient still has to go to a center. Eventually, the technology will get good enough where all of us can just pull out our phones and receive a healthcare service via telehealth right on their mobile device.
Thank you.
Sure.
Mr. Director?
Thanks for the presentation. So a question on your expected results. Restore has recently lost addiction treatment services. Could you tell us a little bit about that? And then this program is telehealth, mobile device supported medication-assisted treatment for opioid disorders. Does Mosaic, working with your partner in Montgomery County, envision this as part of a continuum, a care continuum in which there would be some folks that this would not be appropriate for, and you would need to direct to a inpatient setting for detox? And can you sort of explain how this works within the overall program that you might be planning for Montgomery County, or if that's not relevant in Baltimore?
Absolutely. So the first question about the defunct program as of now. So Family Services, Inc. was operating an outpatient treatment program in Montgomery County, and due to the issues of workforce, was forced to shut down the program because they just couldn't find a prescriber of medication-assisted treatment in that area to be able to work for the kind of money that we can afford. That you always have to throw that in. Your question earlier was, is it always about the money? No, but money plays a huge role in the resources that you can operate under. The second question is a good one. So currently in the United States, we use the ASAM criteria to determine the level of services one gets for addiction treatment. And so the ASAM criteria is part of our initial assessment process. And so during that process, if we deem it necessary to step somebody to a higher level of care that we currently do not provide, such as inpatient detox, then we will make the appropriate referrals. Part of this project's success will depend on the ability to partner with local agencies and other providers along the continuum of care in order for this to succeed.
And lastly, I think the FDA recently announced some approvals for certain non-opioid drugs for detox management. Would those recent announcements have any impact on your program? Are you aware of it? I saw that this morning.
Right. So not yet. Usually it takes about 12 months from an announcement to actually on-the-ground use. Right now, we use Suboxone, Naltrexone, and Vivitrol. That's three main meds available to addictionologists to prescribe for medication-assisted treatment. Once new medications come online and are proven to work as effectively or better, our physicians will prescribe the new ones.
Mr. Chair?
Yes.
Last
Commissioner
week,
Thomas.
I attended a conference on the campus of Bowie State University. It was all on the opiate crisis. The Lieutenant Governor was there. I mean, the word telehealth never came up, which is why I'm going to press you again that these successes you're seeing we can't wait a decade before it finally kind of gets more broadly disseminated. And that may be the commission looking in the mirror in terms of how to get these lessons out. But I would say that having a fairly high-level meeting like that, Lieutenant Governor and other providers, the word telehealth was never mentioned. So we cannot assume that what you're seeing, others are seeing, especially people who are in position to move some of the policy levers that could help you get more resources.
Thank you. So this past session, a telehealth bill was passed. Last session, a telehealth bill was passed. I think it will take this incremental change year after year to add more voices and evidence to telehealth, both technology and outcomes. But you're correct. More people need to know about this.
Any further questions? Ms. Lenoir, Ms. Jefferson, Mr. Tarkovsky, thank you very much. You're doing the Lord's work. Thank you very, very much.
My pleasure. Thank you.
Mr. Director, tell us about upcoming events.
So I will use the time I reserved from the start of the session to just very briefly highlight things that might have been missed. In your materials are two documents summarizing a talking point, press release from Governor Hogan, and a set of talking points on the new Maryland all-payer model, now minted as the Maryland model. It's been announced. The agreement has not yet been signed. What it will do over the next 5 years, by 2023, it will commit Maryland to producing for the federal government $300 million in additional Medicare Part A and Part B savings. That's $300 million per year by 2023, and cumulatively over that first 5-year period, a total of $1 billion in additional savings. The key point here, and one that I think many know, is that the current model focuses on savings under Part A. The state has a number of important levers through the hospital rate setting system to ensure that those savings can be achieved. Under the new program, we will expand the savings commitments, but we will do that going forward with less ability to directly achieve those savings under Medicare Part B, the physician non-hospital component of Medicare. That's one of the biggest concerns on the part of the hospitals, because although they are regulated directly, other providers are not. The state has signaled its intention not to do that, but it does put additional risk on the part of hospitals. The agreement will also commit the state to controlling overall hospital growth, so that for all payers, it does not exceed 3.5%, as it has over the past 5 years. But you will note that medical inflation does seem to be ticking up, so not wanting to report in the future, but it could be more of a challenge than it was in the first 5 years. But we will have commitments on the part of the federal government that there may be some additional flexibility under that provision. We'll also bring into play a number of other initiatives, the most significant of which is the Maryland primary care model, which will be launching in January of 2019. That will align with our effort to care more effectively for patients, to deliver care in a more ambulatory setting, to provide care that's more satisfying to patients and more effective. The state will also commit to defining a set of population health goals that will apply not only to the Medicare population, but to the other populations in Maryland as well. Those will likely focus on reductions in the prevalence of diabetes, effective control of opioid addictions, and perhaps others such as reductions in the rates of Hep C. That process is being worked out. We will also commit to bringing slowly our other payer communities more closely into our ambulatory-based initiatives, including the primary care effort. What does that mean for MHCC? Clearly, what we talked about at the outset is going to be very important, that we have a key role in redefining how our health planning and CON processes align with this new all-payer model. We will also be playing a significant role in the outreach for the Maryland Primary Care Program, which will, although set to launch in January, will really get underway around June 1st with the release of solicitations to engage what are called care transformation organizations that will assist practices in meeting their obligations under this advanced primary care model. The rollout of applications for primary care practices will occur after the CTO solicitation has been almost complete, but there will be an expectation that many of the primary care practices that will commit to this program will be seeking assistance from the care transformation organizations, the CTOs, to support them in delivering the 5 advanced primary care functions. We will continue to be working closely with CRISP, which has an essential role in bringing to bear important healthcare information, not only for the hospital side models, but these new, the new primary care model and potentially other care redesign amendments that will be permitted under the new agreement with Medicare. We will continue to expand and enhance our quality reporting efforts and align them with our colleagues' work at HSCRC. And we'll also be working with all of our care partners to raise awareness about variations in cost and quality, and particularly using that information to inform consumers about their important role in these new models. Clearly, it would be desirable that if everyone knew about the new all-payer model. I think that's very unlikely. I think, therefore, it is more important and more feasible that things that matter most to patients, which are quality, cost, and safety, be better translated to Maryland consumers and patients. It's going to be, I think, quite an ambitious effort. Fortunately, we will have the support of the Centers for Medicare and Medicaid Services, and in particular, the support, it appears, from the leadership of CMMI. David Sharp, Melanie Cavalier, and I spent a day last week at a CPC Plus meeting. A comprehensive primary care meet plus is the national anchor for what's being done here in Maryland with regard to primary care. We had an opportunity to hear Adam Bowler talk about his priorities, which focus on making the healthcare system more transparent, more accountable, and simpler. I think those will be, to Chairman Moffitt's points, something that will percolate through some of the new payment models that are very likely to come out under Adam's leadership. As some of you know, our former chair, Craig Tanio, has worked closely with Adam in the past. He is a advocate for what I would say advanced primary care, community-based services. He speaks not only from a professional and an entrepreneur, but also from a family member who saw their own grandmother's struggle to access appropriate care in the last years of her life. More to come, certainly, but the kickoff of the program will be likely before the next commission meeting. We'll have more to share with you over the coming weeks as the initial phase, the CTO solicitation, comes into play. The second piece of information I wanted to bring to your attention is that next week the state will submit its 1332 waiver application to CMS, to SIO. That was enabled through legislation that was passed this past session of the legislature, and with bipartisan support of both chambers and the very strong endorsement of the governor. This is an important effort emphasized only this past week by the release of the new rates in the individual market. This is absent a 1332 waiver, and these are rates that were submitted to the MIA, not approved, but for the PPO product, which has been labeled one of the major cost drivers, CareFirst was pegging an increase of up to 91% over 2018 premiums. Premiums on the HMO products were nonetheless pegged to rise about 19% in the two products that CareFirst offers in the individual market. Kaiser pegged its premium increases at 34%, in part driven by utilization increases, but they did also point to the significant risk adjustment payments they make to CareFirst to offset the lower risk that Kaiser absorbs in the individual market, and consequently pays to CareFirst to experiences greater risk. That was listed as a contributing factor. Even with the 1332 waiver approval, we will be looking at some substantial premium increases. By comparison, the rate increases in the small group market for the two payers that I mentioned, CareFirst and Kaiser, have ranged from about 2.5% to 4.5%, indicating just how volatile the individual market, both on and off the exchange, is and will likely continue to be. Our role here is to continue to provide information. Last month, you heard Ken Yates-Trotman present the report on the privately insured, covering all segments of the market. That report is now ready for release and will be posted on our website, and we will be sharing it with the exchange going forward. We'll also be continuing to work on our transparency efforts over the next month. We did have a very effective and productive meeting with hospitals and consumers this past week under Linda Barniska's leadership. We highlighted changes we're planning to make, and the release of that will be slated for the July commission meeting. We're looking for expanded reporting and continuation of this effort, with this effort following on with a release of Medicare results in early winter. What was most heartening was the fact that one of the hospitals actually said, we'd like to have more episodes reported. Recall that we're currently only reporting on 4 episodes: hip and knee, hysterectomy, and vaginal childbirth. The fact that some hospitals are beginning to see that this has important value was refreshing. Lastly, last week, again, consistent with what we've seen from Leapfrog, CMS released its latest version of the 5-star rating system, and like the most recent Leapfrog results, Maryland hospitals performed better than they did previously from the November release. We had 4 5-star hospitals: Frederick, Union Memorial, Peninsula, and the University of Maryland St. Joe's. 11 hospitals earned 4-star ratings, 18 hospitals 3-star, 8 2-star, and 5 1-star hospital ratings. We still continue to see our large academic centers struggle under this rating system. There is in part somewhat of a story, but somewhat in jest, but somewhat seriously. When we talked about this with our transparency groups, I did observe that now that we are in the Big Ten, we should be shooting for performance like a Big Ten academic medical center. I would note that the Ohio State and the Penn State and the University of Maryland, University of Minnesota, and the Iowas and the Purdue's are largely 3, 4, and 5-star institutions. And if we want to perform like our lacrosse team does, and not like our basketball team does, we need to step up the effort a little bit on hospital quality. But I think, overall, it was a promising report from CMS. So turning to our agenda for June, it will likely be a story of CON and health planning activities. We'll have a number of CONs to consider. We will also be looking at considering our first set of performance reviews for cardiac surgery, and Linda and her team will roll out a update to a price transparency tool that has not gotten as much attention, but is used in many other states, which presents price variations by CPT code. CPT codes, as most of you know, are the detailed, specific medical definitions of what has been done. Sometimes it's useful. Oftentimes, consumers find them impregnable, but they are good ways to examine a variation in a pretty simple and straightforward way that providers in particular understand.
Thank you very much. Any questions at all? The director? Okay. Once again, all good things come to an end. Do I have a motion to adjourn? Motion? And second? That's nice of you. Thank you very much. All those in favor say aye. Aye. Meeting is adjourned.